So objectives, we're going to explore reported cases of PJP in patients with Cushing's syndrome, background on what Cushing's is. It's been a while since residency. It's a very uncommon condition, actually, and the background about the depressed immunologic response in these patients, the role of PJP in immunocompetent and immunosuppressed hosts, and how they respond to PJP, and what existing literature exists to advocate or not advocate for prophylaxis in these patients. So I'm starting off with a couple of cases. These are not my cases. These are case reports in the literature. This is from Ireland. So they reported 2 cases of PJP in patients with a new diagnosis of Cushing's syndrome. The first case, they had a 30-year-old that was hospitalized. He came in with shortness of breath, leg swelling, bloody diarrhea, fatigue. During his hospitalization, he developed pneumonia with acute hypoxic respiratory failure, required intubation for this. And then they just wrote laboratory findings consistent with PJP. They didn't specify exactly what they tested. And for the Cushing syndrome, they were diagnosed with pituitary adenoma secreting ACTH. Another case presented a 59-year-old male. He was admitted for muscle wasting, weight gain, shortness of breath, lower extremity edema. He's trying to have a fairly large adrenal mass. They started midostane, so it's a chemotherapy agent for unresectable adrenal cancer. He then, like the other patient, developed acute hypoxic respiratory failure, and they reported respiratory samples were positive for PJP. The first case was a little interesting because they had also reported that the patient had like TB and strep pneumonia. So I don't know exactly what they tested, but they had some foul constellation of different things. They actually started treatment for all of it. But there are other, next slide. If I click on it, oh, there we go. So there's other reported cases. There's more than just those 2 cases in literature on PJP in patients with Cushing's syndrome, dating all the way back to the 80s when it was still called a PCP in those patients. And what the trend has been is it's in patients with Cushing's who then get treated for it. So they notice that the PJP occurs right after treatment, either from resection of whatever tumor they have or from treatment of the hypercortisolism. It's not as common in the process of it while they have Cushing's without the actual treatment. So the hypothalamic pituitary adrenal axis is back to residency in medical school. So we have a hypothalamus that secretes CRH that then tells your anterior pituitary gland to release ACTH. That then goes to your little adrenal glands on top of the kidneys, and they secrete cortisol, which has a plethora of activity within our body. So that's the axis that's important, and to recognize when you're undergoing workup for hypercortisolism. The Cushing syndrome versus Cushing's disease. Cushing syndrome, endocrine disorder where cortisol levels are too high in the body, but particularly from certain underlying causes. This includes adrenal tumor, pituitary tumor, corticosteroid use, etc. Cushing's disease is particularly caused by pituitary tumor secreting ACTH. So that's called Cushing's disease. Everything else, which could be exogenous, endogenous, Cushing syndrome. But they act very similarly, except with Cushing syndrome, if you have ectopic cortisol production, let's say from like a neoplasm, they actually find that these patients secrete even more cortisol than patients with Cushing's disease do. So what does cortisol do in our body? So we know it's important for lots of regulation and homeostasis in our body as well. So it leads to gluconeogenesis, acts on the liver, release the glycogen storages, decreases insulin secretion, leads to increased proteolysis, which is why in Cushing's disease or Cushing's syndrome, where they have overactive cortisol, they have a lot of muscle wasting. Includes lipolysis and free fatty acid release, but also a lot of adipocyte storage. They have increased adipocytes, particularly in the visceral areas. Bone reabsorption was why we see osteoporosis in patients with Cushing's syndrome. Also works on your blood vessels, so leads to vasoconstriction, hence the hypertension, again in Cushing's syndrome. And for our purpose, anti-inflammatory and immunosuppressive actions, which we'll go over. So the immune system in hypercortisolism. So high cortisol affects the adaptive and the innate immune response. So it leads to decreased extravasation of neutrophils. So it stays in the peripheral blood. It does not migrate to the peripheral tissues when you have an active infection. This is in chronic hypercortisolism. And it decreases neutrophil apoptosis. So they just stay in the peripheral blood, not really acting on anything. You see a large weakened macrophage response in these patients. And then there's a shifted balance between the Th1 and Th2 cells, favoring a Th2 differentiation and the production of IL-4, which then further enhances Th2 activation. And then with your antigen-presenting cells, it decreases antigen production, and then importantly for us, and particularly for PJP, decreases the amount of CD4 cells and the CD4-CD8 ratio. But though it decreases the CD4 cells, it doesn't necessarily, the ones that remain, doesn't decrease their function, just decreases the amount of CD4 that are actually circulating or made. So this is a table demonstrating what I just discussed. So again, it goes over the different cell types with the innate and adaptive immune responses and exactly what it does, and then like what the clinical readout is or how it actually presents. So for example, the T lymphocytes, the influence in the Th1 versus Th2 response, and its shift toward a more Th2 response. So that makes you more susceptible to intercellular infections, opportunistic infections, because your Th1 cells are more important for that than your Th2 cells are. And then you see significant lymphopenia in these patients. They may not get to the level that you'll see, HIV with AIDS and under 200 CD4 counts, but certainly under 1,500 for total lymphocytes. And again, the reduction in CD4 to CD8 ratio. And then you get decreased opsonization and humoral response, because you also need these T cells to act with your B cells, and you also just decrease in B cell count. So this is one paper that it described the immune response in mice, in immunocompetent hosts and immunosuppressed hosts. So immunosuppressed mice and immunocompetent mice. Murine models are a lot of times used for PJP, because they're fair surrogates for humans in that regard. So take this as you will, because again, this murine model is not necessarily how this acts in a human host. So again, observe response in both innate and adaptive immune systems. It showed that they are both necessary to effectively clear PJP in host. And they emphasize the importance of CD4 cells in these patients. And Dr. Cannell also, he had a couple of papers, but this also further describes the role of CD4 and that this is actually a large player in patients with non-HIV related disease leading to PJP. And some also more than just Cushing's syndrome. So this is the paper I mentioned earlier that described the murine models of how PJP acts in our immune system in both immunocompetent and immunodeficient on the left, immunodeficient on the right. So you get infected with pneumocystis. We have our antigen presenting cells that present the antigen to our T cells via the MHC2. That then leads to what they found is M2 macrophages are more important in immunocompetent hosts and keeping the so we're all exposed to PJP, right? It's fungus, but immunocompetent hosts don't necessarily have an active infection. So how do they actually regulate the fungus and make sure that we don't have an active infection and take care of it? So the M2 macrophages are released. We get cytotoxin action as well. There's still a CD8 reaction. We have our B cells that are effective in creating antibodies. But it's questionable how much that actually plays a role with the antibodies themselves. A lot of it is actually just the macrophage activation. And we then get clearance of our PJP. An immunodeficient host, we don't see that CD4 response and the B cell activation. So when we don't really get the humoral response, which was still like a questionable role if that led to anything, but particularly we don't get the Th1 differentiation. So again, we see more Th2 differentiation. So though you see the arrow leading here, it's showing basically this is not occurring. So in an effective immune response, you should have a favorable Th1 response. And in the suppressed host, that does not happen, you have more Th2 response. And this Th1 response in these patients, I don't know why they had described M2 more so immunocompetent and then M1 macrophages and immunodeficient, but that's the results they had seen in murine models. But with an appropriate response, you'd have more M1 macrophage activation, would then lead to clearance of PJP. So macrophages are important, but also the activation of macrophages is important. So the interaction between the adaptive and innate immune response. The PJP and hypercortisolism. The theory is that in patients with chronic, long-standing hypercortisolism, just have a higher burden of PJP in their alveoli, and it may not be apparent because as their cortisol levels are still very high, their immune response is low, so they're not exactly creating a response to it. And then once they get treated for the hypercortisolism, it's almost like an iris response. And then we see the respiratory distress in those patients. So they think it's a rebound immune phenomenon. They have a chronic low-grade inflammatory response, which I just discussing, that leads to an excess immune response. There's also a reason why in Cushing's syndrome or Cushing's disease, after they get treated, they all of a sudden see this emergence autoimmune diseases in these patients, so RA, Sjögren's, etc. CD4 and CD8 cells are affected, which is a major contributor as to why they think PJP infections even happen in these patients. And then again, poor phagocytosis within stages. So we're going to go over there's not much literature supporting the use of PJP prophylaxis in these patients. You'll see articles that say, yes, you should do it just because PJP is virtually unseen in immunocompetent hosts. So the fact that you even see that in these patients, makes you think about that they should be in prophylaxis anyways. There aren't many studies done to compare patient populations. This is one that was done. It's characteristics mortality of pneumocystis pneumonia in patients with Cushing's syndrome. And it's called Plea for Timely Initiation of Chemoprophylaxis. So the title's already a little biased because you know what they're going to be recommending toward the end of the study. But a single center retrospective cohort study. So they did their own study within their facility, and then they did a separate systematic review and included both of those in the paper. The cohort study included patients from 2003 to 2015 who had Cushing's syndrome. That's a total of 53 patients. I don't know exactly what institution, but they reported they were well known for treating Cushing's syndrome. Again, the incidence prevalence of CS is very low in the general population. Just keep that in mind, which is why the actual number is low. And the systematic review included 14 publications with 15 patients with Cushing's syndrome and PJP. So the retrospective cohort study portion of the paper, again, 53 patients with CS. Of these 53 patients, 5 of them end up developing PJP after starting cortisol-lowering therapy. 4% females median age of 49, and 87% had what they call the common cause of CS. This would be like a pituitary secreting tumor, adrenal adenoma. Less common would be your ectopic foci, so your neoplasms. And what they observed in these patients who then developed PJP was that they had a higher morning serum cortisol, a higher midnight salivary cortisol, a higher urine-free cortisol, almost like up to 20 times upper limit normal for the urine-free cortisol. In the systematic review, they included 14 publications. 15 of these patients had CS and PC or PJP. 13 of 15 patients developed PJP after starting cortisol-lowering therapy. So what we discussed earlier, that we're tending to see the PJP just pronounce itself after they get treated for the Cushing's. Of the 15, 14 had ectopic Cushing's syndrome. So again, likely a neoplasm in those patients. Not like an adrenal neoplasm, but ectopic neoplasm. 8 of the 15 reported the urine cortisol, and 5 of the 8 had it over 10,000. And then the case fatality rate was 11 of the 15. Now take that with a grain of salt. So you'll see like a trend, at least in these 2 papers, with a higher mortality rate pushing patients with Cushing's syndrome and PJP compared to PJP and even the HIV patients. But it's because a lot of these patients are presenting with severe Cushing's syndrome, which in itself leads to higher mortality. So observations from that paper, we see increased PJP with more cortisol excess reflected by the 24-hour urine cortisol, and then higher serum and midnight cortisol levels. And we're seeing a higher PJP with ectopic Cushing's syndrome. So it suggests like in ectopic, again, we might see a higher predominance of it because higher cortisol levels in general with ectopic Cushing's syndrome. PJP developed after initiation of cortisol-lowering therapy, questionable iris-like reaction. Theory, again, is that the higher PJP burden in these patients at a baseline level, and once they get treated, have an increased immune response. And like we discussed, higher mortality rates of PJP patients with CS when compared to like traditional risk factors like HIV or transplant patients. So takeaways, the authors in the very end of the paper suggest initiating high dose methoxyl when there is a high enough risk for Cushing's syndrome. So what they consider like a high enough risk was basically this type of ectopic production, or not ectopic, I wrote the production of cortisol from not like traditional Cushing's syndrome. So again, like a neoplasm. It's a single center study. It had a very small number of patients, although the incidence of CS in the general population is low anyways. And there is no comparator. This is purely an observational study with retrospective data. So we're not comparing, patients with CS that aren't on prophylaxis compared to CS that aren't on prophylaxis. These patients weren't on any prophylaxis. Just, hey, we had these patients with CS. Here's who developed PJP, and then here's what we think the risk factors were. In France, they did a study. So they had Pneumocystis pneumonia in patients with Cushing's syndrome. It was another retrospective study, but across multiple institutions, including cancer hospitals and university hospitals in France. These patients, for inclusion criteria, must have a diagnosis of Cushing's syndrome, particularly a new diagnosis of Cushing's syndrome, and have a diagnosis of PJP. So they didn't look at CS alone. They looked at CS and PJP patients. A total of 25 patients were enrolled, 7 of whom were actually already receiving PJP prophylaxis, not for another reason, for Cushing's syndrome. And they received the TMP FMX 3 times a week. The exclusion criteria were any patients with HIV, patients who are on corticosteroids over 3 months duration, any hematologic malignancies or solid organ tumors beyond the tumors for the CS, any other immunosuppressive disease, a patient on any immunomodulator therapy, like for chronic inflammatory disorders, period, beyond CS, and in any transplant patients, which included BMT and solid organ. So all those patients were not included in this. These patients, for the most part, really had just CS. And this is what we had seen. So this is the patients that had actually PJP prophylaxis. So interestingly enough, they had, let me go back to how many it was. It was 7 patients who were seeing PJP prophylaxis. And of these 7 patients, they actually developed PJP. So despite having prophylaxis, they developed PJP. So they were looking at, okay, so what were their maybe risk factors? What was the reason for Cushing's syndrome? So most of them had hypercortisolism secondary to a ectopic foci, such as neoplasms, like pancreatic neuroendocrine tumors, bronchial carcinoid tumors, lung adenocarcinoma. So all of them had a neoplasm underlying this. Their cortisol levels in general were higher than the other patients in the 25 group. So these 7 patients had higher baseline cortisol, and their initial lymphocyte count was lower than the other patients as well. And even after starting PJP prophylaxis, they still had a lower lymphocyte count, not that would affect as much, and a lower cortisol. And 2 of these patients unfortunately passed away, and they all required at least ICU level care for their PJP.
Were they started on it right after diagnosis?
They didn't specify. Yeah, they just said these patients had PJP prophylaxis. I don't know if one were they adherent to the prophylaxis, when was it started, was it like 3 days after it was started or not? It was just a correlation. I think their takeaway was just what puts them at greater risk for it, but they didn't go into detail for the specific patients.
What about the dosing? Did they talk about dosing earlier?
It was 3 times a week, yeah. Mm-hmm. So observations, the study included patients with CS and PJP. It didn't compare just patients with CS without PJP and patients with PJP. I just looked at what were the risk factors for those that did develop PJP. It was a small study population. It was only 25 patients. And then what they noticed from this small group is that, again, more patients with ectopic cortisol production were a higher risk for PJP. And they reported breakthrough cases. So other patients are on prophylaxis, they still had breakthrough cases, mycosis treatment prophylaxis. So at the end of the study, they advocated for PJP prophylaxis in select CS patients, just like the other paper, particularly those with neoplastic cause of their CS ectopic foci of hypercortisol production. And they also proposed continuing PJP prophylaxis for 6 weeks after eucortisolism is achieved. So after surgical resection or after treatment with like ketoconazole, for example. So they said it was 6 weeks, and they got this number from studies with transplant patients and their risk for PJP after like stopping steroids. So this is the algorithm they propose. So if you have a patient with Cushing's syndrome and their urine cortisol is over 5 times upper limit of normal, then go ahead and go to PJP prophylaxis. And then they also had another criteria where, let's say it wasn't that high, so their innate cortisol production is as high as up to 5 times upper limit of normal. Look at the other factors for them. Do they have any neoplastic etiology? Do they have a planned treatment at risk of PCP or PJP? Do they have a low lymphocyte count under 200? This wasn't based on necessarily this right part on anything in their study. It was just some observations they saw with the risk factors and created an algorithm as to a potential approach as to what to do. So thoughts on this? There's not too much literature to support the use of it, and it's like questionable the fact that they even had patients who were on prophylaxis in the second study and still developed it, but we just don't know the details of those patients, unfortunately, as again, like adherence to medications, when they started the medications, and other risk factors that they potentially had just beyond what they had mentioned for the development of PJP anyways. They report a higher mortality rate in patients with Cushing's syndrome, but there's also a definite mechanism as to why they develop PJP. And again, these patients with severe CS are at risk for other infections beyond PJP, and in general can just be sick from the Cushing's syndrome alone. So they might have increased mortality just again from their disease, not necessarily because of the infections they had acquired. And then papers did not go into the risk of initiating prophylaxis. They also kind of just stuck with Bactrim. They didn't really discuss other risk of prophylaxis in other patients. And there wasn't quite like a number needed to treat, right? Like how many patients did you actually give prophylaxis to that you would see actual beneficial outcome? Because they weren't comparative trials. These are retrospective studies. And that was it. And these are my references.